Welcome again to the Psychiatry Lectures. I'm Sam Asgharian, and we'll start off now with a discussion of the eating disorders that will appear on Step 2. We'll start off with a case. We've got a 15-year-old girl brought to the clinic by her mother who found her vomiting in the bathroom. She vomits daily after each meal and exercises excessively. She has numerous calluses on her hands as well as cavities. She is 5 foot 5 inches and weighs 90 pounds. Let's see what our ask is. What is the most likely diagnosis? So hopefully, based on all the vomiting and all the other issues, the 15-year-old girl, you know it's not obesity. It's not atypical depression. So you've narrowed it down to A or B, bulimia or anorexia. Take a look at the vignette again. Look for the biggest key indicator. And hopefully, you've narrowed it down enough to say it's B, anorexia nervosa. Why is it B? Well, she's got numerous calluses on her hands as well as cavities. So, okay, she's vomiting. She's forcing herself to, so she's purging. But here it is. She's 5 foot 5 and weighs 90 pounds. Someone 5 foot 5 should definitely be over 100 pounds. 90 pounds is way too thin. Therefore, anorexia nervosa is our correct answer choice. People who have bulimia normally have a normal weight. 90 pounds for 5 foot 5 inches is not the normal weight. So let's delve deeper into anorexia nervosa. It's a failure to maintain a normal body weight. In addition, you have a fear and preoccupation of gaining weight and a body image disturbance. Take a look at that image. That unrealistic self-evaluation as overweight is extremely common. You shouldn't see someone's ribs, not all of them like that. That's emaciated. But when she looks in the mirror, she thinks she's morbidly obese. And when you're too thin, the organs start to shut down. The ovaries aren't going to be ovulating, and so amenorrhea is common from low body weight. The patients are difficult to treat because they continually deny their condition. They tell you, no matter what you tell them, that they're too fat and they could still lose some weight. There's a great concern with appearance and they frequently examine and weigh themselves. There's an element of obsessive compulsive personality disorder here. They're rigid, they're inflexible, but it's entirely surrounding an obsession with weight and appearance. So how do they lose the weight? They have a strict caloric control. That's that obsessive compulsive personality disorder. They'll tell you to the 10th what type of caloric range they're taking in. They exercise excessively. They want to balance it out. If they've calculated that they've taken in 504 calories, they'll go on a treadmill or some type of aerobic or anaerobic device until they feel like they've burned off over 500 calories. They'll also purge. They feel bad that there's food in their bodies, so they'll vomit. And that's when you see those calluses on their hands and cavities in their teeth. In addition, they'll fast. They just won't eat. More frequently, you'll see this in teenage girls from 14 to 18 years of age, and there's severe weight loss. Not a little bit to where you say they're underweight, but so much that their BMI is severely underweight. Their blood pressure starts to fall. Their heart rate drops. They have that lanugo hair. What does that mean? It's hair in areas that you wouldn't expect, and it's a different type of hair. It's like babies have that lanugo, newborn babies on their bodies. And so if you look at the arms of a teenage girl with anorexia, there's like a downy hair on her arms, and that's another sign with amenorrhea of anorexia. Edema, there's swelling, there's EKG changes. You'll actually see the cardiac changes as organs start to shut down secondary to deficiencies in nutrients. And that arrhythmia can lead to death. So you want to treat this quickly and you want to treat it from many different angles. It's difficult to get the patient to buy in. The patient doesn't want to admit that there's anything wrong. So you may need to hospitalize and keep the patient inpatient, but you always run the risk of relapse. So you keep them on behavioral therapy for follow-up. It's extremely important. These patients are at increased risk of dehydration, starvation, electrolyte imbalances that can lead to seizures, ultimately cardiac issues that can lead to death. So you prescribe that psychotherapy and behavioral therapy. You can add SSRIs, remember the selective serotonin reuptake inhibitors, to promote weight gain. Remember that's an unwanted side effect? And actually here you want that side effect. And that'll help also with their psychological issues. It'll give them less of a feeling of depression about their body image if they're on an SSRI. From the previous case, an answer choice that definitely looked like it could be correct was bulimia nervosa. Let's discuss bulimia more in detail and discuss its differences from anorexia. It's frequent binge eating in a discrete amount of time. It's a lack of control over those overeating episodes. Basically, what happens is a person will see a whole pie and they'll have to eat the entire thing. Additionally, afterwards, it'll be accompanied by compensatory behavior to prevent weight gain. What they'll do is they'll feel terrible for eating so much in that period of time, and they'll need to get rid of that feeling, and they'll do things by purging. They'll use laxatives and diuretics to get the food through their system faster. Afterwards, they'll go through a period of fasting where they won't eat anything at all, and they'll exercise excessively. They'll also go to the gym for a very long period of time until they feel like they've used enough energy to overcome the amount of food that they've ingested. Their self-evaluation is influenced by body shape and weight. The biggest thing to note for bulimia is these people tend to be normal weight. Their BMI is in the normal range, and that's a differentiator between bulimia and anorexia. The good news with bulimia is that these patients know that they have a problem. It's easier to treat them since they'll admit that they need help. With anorexia, they won't admit that they need help, and so a treatment plan becomes an issue due to compliance. You're going to diagnose more frequently women for bulimia and later in adolescence than anorexia nervosa. Remember, anorexia, you were looking at age ranges between 14 to 18. Bulimia, you'll look at an older patient population. They're mostly normal weight, but they may have a history of obesity. The treatment here, you don't need to hospitalize them. They are compliant. They will actually listen to the treatment protocol. However, if there's a severe electrolyte abnormality, because remember, they'll purge by using those laxatives, those diuretics, by vomiting, you want to hospitalize them until you correct the electrolyte abnormality. You can prescribe psychotherapy as well to help them, and SSRIs. Be careful though, if bupropion is an answer choice, you cannot choose it because of that electrolyte abnormality. They'll have a lower threshold for seizures to begin with, and bupropion lowers the threshold even further. So make sure you use the SSRIs if you are going to choose a medication. Finally, we'll talk about the eating disorder not otherwise specified, that NOS. If it doesn't meet criteria for either anorexia or bulimia, then you can say it's eating disorder not otherwise specified. Let's say that the criteria for anorexia is present in girls, but the menstruation is normal. It's not amenorrhea. Anorexic patient with normal weight. So you have that person who's obsessed and doesn't want to admit they have a problem. You can't say it's bulimic. Maybe it is anorexia nervosa. Or the use of compensatory behavior after eating normal amounts of food. There's purging, but there's no binging. That's eating disorder not otherwise specified. Now we'll discuss the sleep disorders that you'll see on the exam, both narcolepsy and insomnia. So narcolepsy, it's characterized by excessive daytime sleepiness, abnormalities of REM sleep, the rapid eye movement sleep. So here, no matter what the patient says that they're tired during the day, even if they've slept a long time at night, they're still drowsy and tired. It most frequently begins in young adulthood. Sleep studies are usually indicated in diagnosis, so you want to put them under a sleep study. And you also want to keep obstructive sleep apnea on the differential. This sleep study will differentiate narcolepsy with obstructive sleep apnea. Obstructive sleep apnea, they actually don't get high quality sleep, and it occurs in the deeper stages of sleep. Whereas narcolepsy, they get better sleep, but because of their lack of REM sleep, then they have issues during the day with fatigue and drowsiness. The bad news for narcolepsy is that there's no curative therapy. What you can do behaviorally is force the patient to take daytime naps. That extra burst of REM sleep that they didn't get at night will help them throughout the day avoid drowsiness. In addition, you can prescribe modafinil. What that'll do is it'll maintain their alertness so they can function at work or at school. They'll stay focused instead of feeling drowsy or fatigued. So this is important, especially for the test. The specific feature of narcolepsy are sleep attacks. That's episodic, irresistible sleepiness and a feeling of refreshness upon waking. What you note here is that the patient will have cataplexy. That's pathognomonic for narcolepsy. Cataplexy is when there's a sudden loss of muscle tone. It may be precipitated by a loud noise or emotions. A vignette to look for is, let's say, someone seeing a family member for the first time in years. So they go to the airport, the family member they haven't seen in so long comes out of the gate, and all of a sudden they lose muscle tone and they faint. And that's cataplexy. If they have that at a special occasion or they just zonk out at random, that's going to clue you in that it's narcolepsy and not obstructive sleep apnea. In addition, you might see hallucinations from lack of sleep. What you see note here is that basically the hallucinations occur as the patient is going to sleep and waking up. Remember, it's abnormal REM sleep, rapid eye movement. Lastly, there's sleep paralysis. That's they're awake but unable to move. And typically it happens upon awakening. It scares the patient. They'll say, "Doc, I tried to get up this morning and I literally couldn't move. I thought I was paralyzed." That's another key feature of narcolepsy. Another sleep disorder that's important to discuss is insomnia. For insomnia, it's an inability to initiate or maintain sleep. You can't fall asleep. You're in bed, you try desperately to, but you just can't sleep. It could be due to anxiety and depression, and it's definitely severe enough to affect the level of functioning. You'd see this in women who complain of feeling tired or have increased appetite and yawning throughout the day. For insomnia, you want to give them good sleep hygiene techniques. You want to tell them to go to bed and wake up at the same time. You want to avoid caffeinated beverages and avoid daytime napping. Anything that might keep you up at night is something that is bad hygiene. Anything that'll help you go to sleep at night is good sleep hygiene. Behavioral modification techniques include using the bed only for sleeping. A lot of people will read or watch TV or eat in bed, and that'll prevent them from having a sound night of sleep. You can also prescribe medical therapy. This one's good because they're all include or prominently have Z's in them. And so I like to think of, you use those Z's for sleeping. You want to zonk out, so you'll give them zolpidem, ezopiclone, or zaleplone. All of those things should remind you of someone who's sleepy or going to get some Z's. And now we're moving on to the human sexuality section of the psychiatry lectures. So we'll discuss briefly the terminology for human sexuality. Sexual identity is based on a person's secondary sexual characteristics, so their genitalia there would define their sexual identity. Gender identity is different. That's based on a person's sense of maleness or femaleness, and it's established by age 3. The gender role is based on external patterns of behavior that reflect an inner sense of gender identity. And lastly, sexual orientation is based on a person's choice of love object. It could be heterosexual, homosexual, bisexual, or asexual. So heterosexual is a man with a female or a female with a man. Homosexual is same sex. Bisexual is both sexes. And asexual is a lack of sexual orientation. Discussing masturbation for the exam, it's a normal precursor of object-related sexual behavior. All men and women masturbate. This is a fact, regardless of however much someone may not want to admit it. It's problematic, though, if it interferes with daily functioning. Homosexuality for the exam, it's not considered a mental illness unless it is ego-dystonic, meaning the person is not happy with sexual orientation. That can lead to depression and it can ultimately lead to suicide. Then you would want to intervene medically. It may be considered normal experimentation in teenagers. Then they basically define their sexual orientation afterwards. So a commonly tested topic on step 2 is impotence and the different reasons for it. Impotence is defined as the persistent or recurrent inability to attain or maintain an erection until completion of the sexual act. The treatment here, you want to rule out medical causes or medication and then have psychotherapy and couples sexual therapy in there as the treatment option. Basically what you want to note is the person having any erections? Can they have nocturnal erections? If so, then you want to say maybe it's anxiety, performance anxiety, or something psychological. But if they can't have any erections whatsoever, then you want to say the medical cause could possibly be testosterone deficiency, and you'd run tests to do testosterone levels. For premature ejaculation, that's different. That's ejaculation before penetration or just after penetration. That's usually due to anxiety. The treatment there is psychotherapy and behavioral modification techniques. The stop and go method and the squeeze method are meant to basically extend the sexual act and avoid the premature ejaculation. You can also medicate here with an SSRI to avoid that anxiety issue and allow for basically greater pleasure during sexual intercourse. While impotence and premature ejaculation are issues that men have to face, women are faced with dyspareunia and vaginismus. We'll discuss those two now. For dyspareunia, what you see is pain associated with sexual intercourse, not diagnosed if it's due to a medical condition. So you want to do an exam to see if there's any anatomical issues. And if there's pain during sexual intercourse, you want to treat it with psychotherapy to make sure that there's no issues involved or any traumatic events in the past that might be causing the issue. Vaginismus is different. Vaginismus is prolonged and painful contraction or spasm of the vagina. It's usually severe enough to prevent intercourse, and it's involuntary. A lot of times women will say that the same feeling they get when something comes toward their eye, where they have to blink and shut their eyelid, it's the same feeling they get when someone is going to have sexual intercourse with them, or they're even going to try to put a tampon in their vagina, and the vagina will clamp shut. What you want to do here, usually there's a psychological issue that causes this, so you want to treat it with psychotherapy. And you can also use dilator therapy and probe therapy to get them accustomed to having something go into the vagina. Another high yield topic to note are the paraphilias. These are the group of disorders that are recurrent, sexually arousing, and seen more frequently in men. They usually focus on humiliation, either for the person or for the object that the person is infatuated with. There are non-consenting partners involved and the use of non-living objects. Most occur greater than 6 months and cause distress. They affect the level of functioning for the person, but you can't diagnose if it's just experimentation. A lot of times people experiment with some of these paraphilias before they realize it's just not for them. You want to make sure that that timeline greater than 6 months is somewhere on the vignette so that you can go ahead and diagnose the paraphilia. The first type we'll talk about is exhibitionism. So exhibitionism is the recurrent urge to expose oneself to strangers. You might note that in sports that are arenas and stadiums where someone has to flash or go streaking across the stadium naked. That's exhibitionism. Fetishism is different. That's the recurrent use of non-living objects to achieve sexual pleasure. It could be anything. A lot of times it could be shoes, it could be leather, it could be fur or feathers. It's something non-living that they require for sexual pleasure. Cross-dressing is a fetishism. So men that need to be wearing women's clothing in order to achieve sexual pleasure are partaking in that type of fetish. Pedophilia, that's recurrent urges or arousal toward prepubescent children. Again, that's something you want to be super aware of because that could lead to illegal and very criminal behavior. And masochism, that's the recurrent urge or behavior involving the act of humiliation. These are people who order, based on internet ads or newspaper ads, dominatrix services. They need to be humiliated, so they'll get on their knees or they'll be whipped or chained and whatnot. And again, these are strange. They have to occur for more than 6 months, but they are prevalent, more prevalent than you would assume in society. So with masochism comes sadism. Sadism is the recurrent urge or behavior involving acts in which physical or psychological suffering of victim is exciting. So these are people that don't want to be hurt. They want to be hurting someone else, or they want to see someone else being hurt. So rather than have them be tied up, they want to be the one tying someone else up, or using different types of candle waxes and clamps and whatnot throughout the issue. And again, this isn't something that you want to just say, oh, it's okay, you're experimenting. If you believe that it's affecting the level of functioning, you want to go ahead and prescribe treatment. There's the transvestic fetishism. So that's kind of what I was talking about before. It's the recurrent urge of behavior involving cross-dressing for sexual gratification, usually in heterosexual males. There have been famous people in the media world that have had this issue that are known for cross-dressing. People in government positions, people in sports positions that are men. They're heterosexual. They enjoy sexual intercourse with women, but they need to dress up as women. They'll wear high heels, they'll wear women's underwear and undergarments. That's a specific type of fetish, and you might want to note that for the exam. So here's one that you'll see throughout the practice questions that you do, and possibly on test day as well. The word is extremely strange. It's frauderism. So frauderism occurs on the exam because it's difficult to remember that exact term. It's the rubbing of one's pelvis or erect penis against a non-consenting person for sexual gratification. People engaged in frauderism love crowds. They love being in very crowded situations because it gives them ample opportunity to get away with this act. So in a subway car, possibly on the vignette, you'll hear about someone who constantly rides the train waiting for the high traffic times to then get up and rub his erect penis against females who are non-consenting, obviously. They'll go to concerts, they'll go to crowded arenas and whatnot and constantly do this. That's frauderism, the need to rub one's pelvis or erect penis against a non-consenting female. It almost always occurs, obviously, in males. So look for that in the vignette. So I touched on you wanting to step in as the physician and prescribe treatment if it's affecting functioning. You're going to prescribe individual psychotherapy. Behavioral modification techniques have also proven helpful. That's the aversive conditioning. That's when you give them something that isn't good. You tell them this is the punishment for some behavior that you don't want them to engage in, such as the paraphilia. Anti-androgens or SSRIs are used to reduce the sexual drive. A lot of times people will say, I can't control it, right? I can't get ahead of this feeling or this sensation or compulsion. Then you can prescribe anti-androgens or SSRIs, and that'll help curb their sexual drive and ultimately the paraphilia. For gender identity disorder, which you want to know, it's a persistent discomfort and sense of inappropriateness regarding the patient's assigned sex. They'll be males, but they'll definitely feel like they're females. The diagnosis occurs when they tell you that they're wearing the opposite gender's clothes, that they're using toys assigned to the opposite sex, that they play with opposite sex children when young. Remember, that's important. When you're young, boys tend to play with boys and girls tend to play with girls. So if a boy is playing with girls mainly at a young age, that could be a sign of gender identity disorder. And an unhappy feeling about one's own sexual assignment. They're upset. They are jealous of girls when they're men because girls get to do all those things and they don't. That's another clear indicator of gender identity disorder. And what they do before they come and seek treatment is they'll self-medicate for the most part. They'll take hormones when they're older to deepen their voice if they're female and they want to be a male, or to soften their voice if they're a male and they identify with the female gender. Women may bind their breasts, and that'll prevent them from growing bigger breasts. Men may hide their penis and testicles. In addition, it's seen more frequently in young men. It can occur in females. Females can definitely have gender identity disorder. It's just seen more frequently in men. You want to say, okay, it's fine if there's gender identity. You can seek sexual reassignment surgery if it's approved, and it requires sign-off basically from a psychiatrist and ultimately sessions, individual psychotherapy sessions, to help them cope with this disorder. We'll finish up this lecture with a brief review of suicide. So here are important things to look for in a vignette that has questions dealing with suicide. Has there been a recent suicide attempt? Are there complaints about having suicidal thoughts? Is there an admission of suicidal thoughts? Right? Is the person telling you that they have in the past or are currently thinking about suicide? Have they demonstrated suicidal behaviors? And that's important. Are they buying weapons? Are they giving away their possessions? That's a key one. When someone's older and they're starting to give away their possessions, that's a clear sign that they've already made a plan to initiate suicide. Are they writing a will? That's not necessarily as strong as giving away the possessions, but it's also an indicator you want to watch out for. So what are you going to look for? You're going to look for males, older males, With social isolation, meaning maybe they've lost a lot of their loved ones and they're left basically alone. Is there a presence of psychiatric illness or drug abuse? Is there perceived hopelessness? Are there previous attempts? And if so, the treatment is super important. A lot of the questions revolve around treatment. You hospitalize the patient. It doesn't matter if they tell you today, right then, that moment, they're not suicidal. If you think they're at very increased risk for suicide, you want to admit them. And ideally, you want to admit them to the psychiatric unit if that's an available answer choice option. You want them monitored appropriately. A lot of times it'll say, oh, keep them in the ER for observation. That's incorrect because in the emergency department, they don't have the correct monitoring capabilities for at-risk suicidal patients. You want to put them in the specific psychiatric unit if you can, and you take all threats seriously. So if it looks like they're suicidal and they have been suicidal, and now all of a sudden they say, oh, not really, I'm not really that suicidal, it doesn't matter. Go based on what recently the vignette tells you, and that'll help you with suicide. And ultimately, I know this is a bad note to end on. Hopefully this lecture has helped, and now you're ready to go through some practice questions to better prepare for this section.